All right, excellent. Well, again, welcome everybody. As you can see, this will be recorded. We will be allowing public comment in the chat box. We will not be responding to that unless the comment is from a committee member and directed to the committee. Our time is limited as we sort through the tasks that we have, so we're going to just restrict communication and responses in the chat directly to members, but certainly we will look at those comments and, if appropriate, respond to them. One of the things I did want to do today, as a result of one of the public comments last week, was questioned, how were members of the committee selected? And I want to just walk through the process so both folks on the committee and who may be listening in understand the process that we went through. So as you're all familiar, we were directed by Gross Senate House Bill 5693 to establish a committee. It stated, or work group, it stated how many members we appointed and from where those folks should come, and listed some specific requirements and credentials for the members of the group. When we started the process, we contacted the following organizations asking if they had persons that were interested or they felt would be appropriate. Those were other state agencies in the form of the Department of Social and Health Services, the Department of Veterans Affairs, the Department of Health, the Washington State Nursing Commission. In addition, we reached out to Disability Rights Washington, the Office of Developmental Disabilities Ombuds, the Liquor and Cannabis Board, the Cannabis Alliance, the Department of Agriculture, the Washington Medical Commission, the Psychedelic Medicine Alliance of Washington, members of the legislature, University of Washington, Washington State University, the American Psychedelic Practitioners Association, and to all 29 federally recognized tribes in the state. We received numerous recommendations from members of the community. We created a website with the contact information, and we advertised positions that we did not yet have filled. In particular, one that we were looking for volunteers or guidance on were people with lived experience. We sent out a delivery message to community members, letting them know we were looking for members to serve on this work group and directed them to the webpage. Similarly, or in addition, we received some emails with resumes and or letters of interest. Most of those came in actually after the committee, required committee members had been appointed. Overall, we reached out to about 500 potential members and received more interest than there were spaces on the committee. The impetus of that, the question from last night, I think, was really also focused on the inclusion of people who are diverse in an effort to address health disparities and inequities. And, we went through the process that we did, and we are in the proviso directed to look at a social opportunity program, or how that would be included in our recommendations to quote, establish equity and help remedy harms resulting from historical injustice and the disproportionate and targeted enforcement of drug-related laws on poor and marginalized communities. So I think what our task is as we inform this legislative report, that we would be inclusive or include within that ways in which to engage communities that are currently not part of this committee in whatever recommendations this group makes going forward. So that, for instance, one of the recommendations that could be made is we recommend that whatever policy or process be enacted have a X member board of X members with these, characteristics to assure whatever. So we're not going to solve the equity issue in this, and I don't think that's our charge, but I do think we will want to make an explicit recommendation about how equity issues can be addressed both broadly, but also how we include a variety of voices, types, and people from different racial and ethnic groups, disability communities in this work going forward. So hopefully that addresses the question and going forward. I think in the interest of time, I'm going to turn it over to Mike. He can go through the agenda and set us. Actually, I'm going to not turn it to Mike. I think you've all seen the agenda. Today, we're going to hear from Jim Morgan from the Liquor and Cannabis Board, followed by a presentation from Duncan Stewart, who is working with the Center for Evidence-Based Policy on his really informative and cool overview of the national landscape, what's happening in other states. Mike will then lead us in a discussion of the survey results. Thank you all for participating and sharing your thoughts on the second survey. And that should take us to about time. If you have comments, please you raise your hand. Feel free to speak. I hope this is a conversation and not just a sort of didactic session that you all feel you're part of. So with that, I'm going to turn it over to Jim, who's going to talk to us about the Liquor and Cannabis Board as directed in the proviso.
Great, thank you. So as far as why Liquor and Cannabis Board is part of this group, it was included in the proviso, specifically why I was tagged to be the representative of LCB. It may not be apparent from my regular job as the Chief Financial Officer, but I am the executive sponsor of the project that has brought us our new traceability system for cannabis. So that experience is why I was selected to participate here, and that's in large part what I want to share with you today. The proviso directs the group to consider the systems and processes at LCB to determine their applicability for psilocybin, and just to learn from our experience. And I think I'll just give the too long didn't read. I think there are a number of things that really are not applicable in our experience, and then some that may be quite applicable, but not directly applicable, just in general applicable. And I'll put some more context to all of that. So first, as far as what's really different and probably isn't going to be helpful from our experience with cannabis is that we're regulating a commercial industry where we have roughly 1,800 producers and processors out there growing and processing cannabis into a wide range of commercial products to be sold out of about 500 retail stores for anybody that's over 21 that wants to participate. Now, part of that is medical cannabis directed towards medical patients, but that's not the they get served from the same stores. There's not a separate medical market anymore. So that's really the big difference. A lot of our processes are around licensing, regulating, collecting taxes from those cannabis licensees. Now, licensing in some form or fashion is probably going to be one of the similarities. There will need to be some sort of licensing for the different players in this industry, and we may be able to share some of our lessons learned there. Probably one of the similarities is is the fact that both are Schedule I drugs that as far as the feds are concerned, regardless of whether we legalize them here in our state, are still illegal. So that represents a number of challenges. So I won't go into that because that's really kind of stating the obvious. So as far as what probably some of the lessons that we've learned with traceability, and that's kind of the general description of our system where we track and trace cannabis as it moves throughout the supply chain. a big lesson that we learned early on, and we've been at this, sales have been going on for eight years now, is that and especially early on, there were no systems that were really good at and really tailored for tracking cannabis. The original system that LCB contracted for was kind of converted from a pharmaceutical directed system and rebranded and repackaged for cannabis. We used that system for about 3 years, and through that time we came to the conclusion that it wasn't meeting all of our needs, and the amount of changes that would be necessary to really make it meet our needs went beyond the scope of the original procurement, and we were required by our procurement rules to do another procurement. That vendor was welcome to submit a proposal to continue as our vendor. They chose not to, and we ended up with another system. We used that system for a little bit less than 3 years that we were contracted for. We learned again that that was very challenging. That particular company, their system for us really was very problematic. The launch was problematic. The continued support was problematic, and both we and the vendor, sometime more than a year or so ago, we're looking forward to June 30 of this year when the contract was up, and really recognizing that neither we nor the vendor were really interested in continuing with that system.
Jim,
Now,
can I stop you 1 minute? I just want to direct a question in the chat to you before we go forward. And Emma asked, you mentioned licensing earlier. Is that for the service centers, facilitators, growers, transporters? Who has to be licensed within this process?
a number of folks. There are 3 primary license types. There is a producer license for, and they're the growers, the farmers. There's a processor license, and those are the folks that are converting the cannabis into any number of different kinds of products. It could just be dried flower for smoking. It could be extractions for edibles or topical applications, all of the different retail products. And then there's a retailer license. So those are the 3 primary license types. There is also a transportation license, so that there are companies that will, they're not necessarily distributors, but they will move product from a processor to a retailer, and they have a license from us, so that if they're stopped by the state patrol, they have protection from having that product. And we also have a research license. There's only 1 or 2 of those, but that's a niche that was identified and we carved out to allow researchers to also have those protections. The protections are really kind of a safe harbor for holding the product, for possessing the product, because it's still illegal for individuals to have over a certain amount of cannabis, unless you're licensed and unless you meet, you're an industry participant. So those are our licenses, and it, the centers, the growers, there would probably be a need for licensing of those as a comparison.
Thank you.
So system-wise and tracking-wise, we came to the realization, part of the reason why the last system that we had failed or failed to really meet our needs was we made it too complicated. We went beyond what was required of us in statute or rule, and some folks in the agency who were part of that project were able to get things that they felt important about added to the system, but that really, in retrospect, maybe didn't add that much value. So the system that we're on right now is a homegrown system, and our requirements for this system really started by really taking a hard look at what is required for us to meet our regulatory responsibilities. And that's reviewing the statutes, that's reviewing the rules, that's reviewing kind of what's necessary to fill in the gaps to meet those overarching goals there. And requirements for the system were developed. And it's actually a very simple system. We went live with it last December, and all of those licensees, each license type has certain information that they are required to report to us. It's not real time. There's not a application interface as there was in the old system where it was almost real time. We came to realize that that level of immediacy was really not critical to us. Most of the issues and problems that we discover are discovered by observing them. An officer goes out to a producer and discovers that plants are not tagged or that they're not logged in the system. Well, having an immediate up to the minute system really isn't going to help that, because if they're not in the system, we're not going to see them in real time anyway. So we went to a weekly reporting requirement, and the similarities will be that there will be certain things that are important for the regulator to be aware of and to keep track of. What's being grown, how it's being processed, how it's being distributed and used. Those in broad brushstrokes are the same things that are important to us. The details are going to be very different. Growing cannabis and growing mushrooms are a very different endeavor, but the general concept of you need to know what's out there being grown. You need to know who has it, what they're doing with it, and what ultimately becomes of that. So the tracking system for psilocybin will follow those same kind of tenets that we have. So as far as the system goes, it's technologically very, very simple. We have a database that was developed to collect all of the data from all of these licensees every week about the things that we identified as being important. Now, the mechanism for getting the data into that database is about as non-technical as is possible, and that is we have defined file formats for CSV files, comma separated value files, where we've defined the information that these licensees need to provide. They've had their software vendors for their in-house tracking systems develop reports and routines that will create these CSV files for us. And just to put it in context, a CSV file is really nothing more than it's like a spreadsheet, and instead of having cells representing the different fields going across on each row, there's commas separating each one of those. And you can actually make your own CSV file with a save as function from an Excel file. So that kind of puts into context how simple that is. So those are uploaded through a portal on our website. And there's some initial error checking and validation, make sure that they're complete, that have all the elements that we require. And in some cases, there's some dependencies. If they say this, then they also have to have included that. Once it passes that error checking, it's either uploaded into our database or an email notification is provided back to the submitter to let them know that their upload failed and what they need to do to correct that. As far as complexity of the application, there's really no application. Once the data goes into the database, we run queries, we run reports from that data to tell us what we need to know about that. There are no business rules. There's no nothing with that data gets changed or moved or massaged in any way once it gets into the database. So that process could be something that would be applicable and useful, and particularly just looking at the overall landscape. If we've had difficulty finding vendors to meet the needs of cannabis regulation, which is now in some form in 39 or so states, finding a vendor with a proven solution for tracking psilocybin is even a much taller order. So it's just something to consider there. And I see there are questions, and we don't have unlimited time, so maybe it's a good idea to go to the questions. And you're muted.
Yeah, thank you, Jim. Yeah, I think some of the questions and comments raised by the committee, and I just want to sort of, for some context, we're hearing from Jim and the Liquor Control Board this week. We'll be hearing from the Department of Health at our next meeting. They're the ones that in the proviso are officially tasked with the regulation recommendations around this. And I think this presentation is to sort of give you an example of how the LCB regulations have worked, or the structure around which the cannabis industry is regulated. So not to presuppose, not to suggest, not to say we'd want to replicate this, just to help understand how that process was moved forward. And then, as I said, next week we'll hear from the Department of Health and what their abilities or comments are around this process. I think and I want to just stop and see if any members of the committee would like to ask Jim any further questions.
Are there any in the chat that you'd like me to address? The last one there, the lottery system. The reason there was a lottery system for licenses is that cannabis is a commercial industry operation, and we had a cap on the number of licenses that we could issue. So there had to be some way to fairly, without subjectively deciding who would get licenses. I doubt that would be the same for the service centers that you're looking at. I don't think people are going to perceive that this is going to be a gold mine like they perceived cannabis to be a get rich quick scheme. And Cody, I see your hand up.
Yeah. So Just out of curiosity, the initial impetus for imposing the lottery system was you felt that there would be a rush of individuals who would be coming into the market and then flooding the market, and then many of them would, lose their investment. Is that correct?
Yeah. So let's address why there was a limit. The limits were in place. They weren't imposed by LCB. They were decided for us in the initiative. And the basic logic there was based on the number of liquor stores that LCB used to run. If that was good enough, if that was enough to provide service to across the state, then for liquor, then it would be enough to provide service across the state for cannabis. Now, the reason why there was a limit, there's no limit anymore on spirits retailers after that was privatized. But a really big difference between spirits and cannabis is there's a secondary market. There's a secondary industry for cannabis that's not there, unless you're in the back hills of Tennessee and you see the puff of smoke from somebody's still. There's an illicit market running parallel to the regulated market. So
Yes.
one of the primary drivers for our regulatory system is making sure that product did not divert from the regulated system into the illicit market.
Sure.
And so if we allowed overproduction and that was the thought process there.
Yeah.
If we let it just go wide open, and other states have had considerable problems with overproduction, too many licenses, and in Oregon, the last couple of years, the U.S. attorney has been very interested in how their system allowed for overproduction and diversion to the illicit market.
Yes.
And we've been fortunate not to have that situation here.
I would say rather, the diversion to, a black market would be in the case of alcohol or distilled spirits. There's a significant health risk to producing it in the black market from methanol poisoning or such that you don't necessarily potentially run the risk with cannabis. Once again, yeah, I'm little, with applying some of these tracking systems and licensing, it's like one-to-one comparison between cannabis and psilocybin. I'm a little bit skeptical of that, and I do know. So, for example, Senator Saldana has proposed a homegrown cannabis bill. So, I mean, many other states in the country they have homegrown cannabis that's perfectly legal. And so I'm curious how such an implementation of homegrown cannabis would change the tracking system on the under the LCB's purview, and whether or not that is really appropriate for psilocybin to begin with. And could you extrapolate a little bit upon that?
Well, we're just regulators. We're not proponents of cannabis, which is actually a pretty big difference from the stakeholders that are a lot of the stakeholders represented here. So, first of all, the home grow is a perennial legislative proposal. I don't think there's been a year. I've been with LCB 6 years. Every year there's some sort of bill that would allow home grows. I'm not really in a position to speak for or against that. It would create a lot of challenges to us as a regulator, and we reflect that in our fiscal notes. We have to do a fiscal note when a bill comes out that says this is the work that we identified based on this bill is written. How would we do that? Certainly, having things in people's homes is an entirely different deal from having them in a place of business that's licensed by us. So, how it would work, your guess is as good as mine. Would it
Sure.
work? I don't know. Should it happen? that's not up to us to decide.
Yeah, I totally get it. Yeah, you're not, once again, yeah, you're regulators. You're not in the business of writing the laws, but we are proposing suggestions to the legislature who will be writing the laws. So, I think we have a bit of impetus here to be, crafting the best suggestions possible to the legislature to ensure that those laws are crafted in the most appropriate way possible.
Yeah. All right. Any other questions or comments that you'd like me to address?
I have if not for Jim, I do have a question for the committee. And I didn't think to ask it last week, but I think would help, at least from the healthcare authority's perspective in helping to move this report forward. The folks can currently obtain products with psilocybin. I mean, they must be, because people are using it and advocating it at research centers. So how would someone go about obtaining it now? And beyond the increased availability that would come from whatever the committee decides to put forward, how would that change? And would it be less expensive, more expensive? I'm just trying to understand, like, the added benefit to making it a more formalized way in which to access and use it than currently exists underground, as it were. And that may be a naive question, but I think someone will probably ask it of us at some point as an agency.
So I'll just take that from the perspective of LCB and the cannabis industry, and I think it's going to be really challenging to answer that question. In the case of cannabis, and we've just recently got a new study, the price in the regulated market is less than the price in the illicit market now, and for any number of reasons, that there are 1,800 producers and processors out there, and we know that in each one of those producers has a limit on how much they can grow, and our surveys and our experience shows that across the industry they're not growing up to the capacity that they could grow. So there's plenty of product in the pipeline, in the supply chain, to keep the prices low. Even with the excise tax, even with the product testing that they have to do. Now, I don't know anything about the economics of the psilocybin marketplace. Clearly, it's out there. It's been out there a long time, but not nearly as prevalent. I think all of us probably know somebody who has purchased, even before cannabis was regulated. You could find a way to find somebody to buy cannabis for you. I don't know that it's that simple and that prevalent for psilocybin. So that makes it a very different prospect for understanding the dynamics of the economics of it all.
I see a question from Jermaine and then Cody. I'm sorry, I keep mixing your names up. I'm sorry.
Charissa, I think that you were asking what would be the benefits of a regulated system over the current underground system. Mm-hmm. And speaking as a psychiatric nurse practitioner, probably the strongest benefit that we're hoping for is a standardization of dosage, is of a safety and regulation of components. And also, just in wondering how much stuff costs, there is such a broad variation, because for many people, the cost is nothing at all, because people wild gather who are knowledgeable. Right. And therefore, any cost that we put on our regulated practice would exceed what a number of current illicit users do spend, but they would be exchanging that for the comfort of certainty about what it is they're ingesting.
Thank you. That's helpful. Cody and then Sunil.
Yeah. Yeah, Charissa. Yeah. So I was actually just going to echo a little bit of Jermaine's point there, in that, I think there is, of course, a black market, and then the regulated market. There are individuals who, once again, want the certainty, who feel comfortable with a structured system, who wouldn't otherwise normally go out and pursue, the consumption of cannabis. Of course, psilocybin and cannabis it's not a one-to-one relation here. The 56 model is not similar to the cannabis market. We're not talking about frat boys who are running off with mushrooms and taking them at parties. It's not like liquor. It's not like cannabis. So I do think, yes, it's good to have some structure there for the individuals who might not otherwise feel comfortable with the consumption of psilocybin, growing it in their backyard or what have you. But I do ultimately think that it should still be as accessible and as affordable as possible for those individuals who are pursuing it through the structured and through the regulated market. And so have a deep skepticism that the similar tracking procedures that you find for cannabis or distilled spirits is really necessarily applicable to what we have for psilocybin here, especially considering these individuals are going to be under the supervision of psilocybin service providers. Frankly, I mean, my suggestion, just from going over all of these points, I think ultimately my suggestion would be the regulation of psilocybin as a food product, similar to growing oyster mushrooms, and then rather than going through this really regimented tracking system with a specific licensing for the producers and for the psilocybin service providers. So, it's my 2 cents.
I want to go to Sunil and then we'll need to move to Doug. I think Sunil, you're muted. I apologize. I keep covering my ears. The Blue Angels are flying directly over my house at intervals. So I'm sorry. If I can't hear you, it's just because I can't hear. So Sunil, yeah, you had a comment. We're not able to hear you if you're talking. Still not quite able to hear you, Sunil. Did anyone else hear him, or is it just no? Okay, Sunil, we're still unable to hear you. I don't know if you're double muted, if you have something you want to type in the chat till your sound is figured out, whatever. I know you're trying to tell us something. You'll type perfect. Okay. Jim, thank you. I want to just in the interest of time switch to Duncan, and we have planned for some time at the end for some further questions and discussion. Oh, Sunil, maybe you flashed on for a minute? No. Okay. All right, Duncan, are you ready to start with your discussion?
Yeah, can everyone hear me? All right, so hi everybody, I'm Duncan Stewart. I'm with the Center for Evidence-Based Policy. And over the past few months, I've been doing research into state legislation and ballot activity regarding psychedelic drugs across the US. And what that has resulted in is a memo and a state grid, which is under review. It's being edited by the by the center at the moment. And so what you have today is just kind of a compilation of what I've done and summarizing my research. Next. Okay, so across the US, 21 state bills and ballot initiatives have been introduced. 8 have passed, 5 are in committee. And then of the remaining 8 that have not passed, 3 have shown substantial promise and so are being brought up next session. On top of this, the bills have bipartisan support, bipartisan co-sponsors, and are passed in both red and blue states. So that you can see that there's support from both sides of the aisle. And then on top of this, most of this legislation, 19 of the 21 bills have been passed in either 2021 or 2022. And usually when something like that happens, one state will pass a piece of legislation, then other states will kind of piggyback off of that and copy it. And what's unique about these pieces of legislation is that that's not the case. So really there's a tremendous amount of variation in the legislation, which makes it slightly abnormal. Next. Thanks. So this is the list of all the states that we have and their status in various houses and the Senate. And so what I'm going to try to do today is kind of give you a scope of the national landscape, but on top of that, what I think is so valuable about all the states having such variation in their legislation is that they kind of can serve as learning lessons and can show this work group what we want to what the work group wants to incorporate into the recommendation, and also what the work group wants to avoid. And so I'm going to work through that and establish some definitions along with just painting a picture of the national landscape. Next. Okay, so here's my little walkthrough. I've divided the bills up into these categories. Most of the bills fill at least 1 or 2 of these categories, but for ease of kind of discussing each of the aspects of each bill and ballot initiative, I'm going to kind of work through them through these categories. And then at the end, I've established these bill model designations that are working definitions to categorize each bill or ballot initiative into a distinct category so that we can better discuss what kind of framework we think would work best in Washington. Next. So we're going to start with substances up for approval, and states vary on which substances, which psychedelic compounds are proposed for therapeutic use. It should be noted that there's no mention of microdosing in any of the existing legislation. No state has yet to even mention it in any sort of bill language. And so I have taken kind of the existing range of proposed substances that states are incorporating into their legislation and have put them into 4 tentative categories, starting with natural medicine. So that phrase natural medicine is used in the legislation to describe the 5 substances that you see next to it. And what I think is interesting about that is I think there is an associated stigma with psychedelics. And I think that is an interesting way to kind of avoid that, and highlights what I think is a kind of a strong aspect of certain psychedelics is their natural nature. Next, we have therapeutic medicine, MDMA, psilocybin, and ketamine. That category is therapeutic medicine because those 3 substances have the most research backing behind them. And so states looking for like a strong research base and strong support so far in terms of current research would go by those 3 substances. Then we have bills under the psychedelic medicine category, which incorporate all psychedelics that have been studied and suggested for psychedelic therapy so far. And these bills often include a provision such as if a new psychedelic drug comes up, it can be reviewed by the Department of Health or the advisory board and incorporated into the existing program, whatever that may be. And lastly, we have psilocybin. So 12 of the 21 bills refer exclusively to psilocybin. And so they are focusing exclusively on implementing or decriminalizing that substance. Notable exceptions. So Rhode Island includes buprenorphine in a psychedelic drug bill. And then Utah, you'll see this throughout the presentation, Utah is given a tremendous amount of leeway. And so the advisory board is fully in charge of choosing which substances are included in the bill that will eventually be passed or recommended to the legislature. Next. So in 16 of the bills, there's a research directive. And that's a broad word to refer to anything that directs any sort of state body or group to go and do research in any form. So 11 states propose establishing an advisory board. I use the term advisory board to encompass a large grouping of different organizations. Advisory boards, as I'll discuss later in the slide, are made up of a lot of different people and are constructed in different ways. And then the remaining 5 states leave research to an agency or agency of state government. So like the Department of Health, and the Department of Health can do research internally, or can contract an outside nonprofit or an institution, a research institution, to do that research and then recommend that research to the legislature. So advisory boards generally have membership compositions in mind. So in the bill, they recommend certain individuals with certain expertise, as you know, being part of this work group. And despite that, they vary greatly in what is included in terms of the expertise. So most advisory boards incorporate experience in therapy, medicine, public health, drug regulations, substance abuse issues. But then there's more variation as we get to issues such as indigenous rights, equity, harm reduction, agriculture, and veterans. Only certain states incorporate those. No state incorporates all of them. There's a lot of variation in that case. On top of that, there's certain states that have advising boards that are kind of outside of this entire category. And so the appointments are based entirely off of different criteria, such as the governor gets to make 2 appointees, or they're using an existing body. So there's a lot of variation to advisory boards, and there's also a lot of variation to how much power advisory boards are assigned. Next. Thanks. So public availability and or target diagnosis. This is a really important category to this work group. States vary in their bill language on whether a medical diagnosis is necessary to receive treatment. And so all states except Oklahoma require a minimum age of 21. Oklahoma is 18, strangely. And almost all states are allowing the treatment to be available to the public except for Georgia, Maryland, and Connecticut, which restrict treatment to veterans, or in Connecticut's case, veterans, first responders, and healthcare workers. But when a medical diagnosis is required, there's a lot of variation on which diagnoses are eligible for psychedelic therapy. And so all states include depression, and most include anxiety and PTSD, but just like we saw on the last slide, there's a whole lot of variation in terms of what other diagnoses are treated or are not treated. And so substance use disorder, traumatic brain injury, et cetera, are some of those that are included in some bills and not others. Oklahoma, it's also worth mentioning, makes the distinction of treatment resistant for depression and anxiety in their bill, which further kind of restricts access to who is able to receive treatment and who is not. And then certain states also leave the decision of which diagnoses are eligible to be treated and which are not to a work group. Thanks. Next. There are also decriminalization directives included in this bill. So it's not simply facilitation bills, there's also decriminalization bills. And in my research, I identified 3 distinct categories for how states attempt decriminalization. Firstly is possession legislation, which means that a certain amount is possession of below a certain amount is decriminalized, therefore there's no jail time, no longer a felony, and usually a fine associated with it. The fine revenues often go to some sort of addiction treatment organization. And like in all of these other instances, the amount that is decriminalized varies widely, from 4 grams to 28 grams to 1.5 ounces. The second category of decriminalization strategy would be to reclassify the drug within the state. So while the drug remains a Schedule I drug at the federal level. At the state level, the drug is reclassified out of the Schedule I classification, which means that if state law officials are involved, it is not considered a Schedule I drug. And then lastly, there can be decriminalization bills in the state or a decriminalization movement that decriminalizes all legal drugs broadly. And so that can take the form of legislation or a Supreme Court ruling, et cetera, et cetera. And that decriminalization, as we know, is so important because not only is it important for equity, but also for the ability for facilitators and producers to produce or do what they're trying to do without the scrutiny of law enforcement. And so 7 have possession bills, 2 are reclassification, and 3 are broad decriminalization bills. Next. Okay, so equity is another huge important topic for this work group. 11 states mention equity in their legislation, but there's a lot of depth in how much detail they go into in the legislation. And so the first 5 states mention equity and call for the advisory board to do research and incorporate equity into their whatever they suggest, whatever they recommend to the legislature or governor. But the equity section in these states is very short. So it outlines equity as a priority, but it doesn't go into detail elaborating on how one would do that, which means that it is up to the advisory board in these states to create a system and make concrete recommendations, but there's nothing in the bill language that facilitates that. And only Colorado and New York of those states have advisory board members focused specifically on equitable policy. Hawaii and Maine are kind of a step down from that. They call for the program to be safe, accessible, and affordable in the bill, but do nothing to direct the work group or any other organization to make this happen. Some other notable inclusions are Maryland has a $1 million non-lapsing fund to cover the treatment of veterans in the state, so that would be a cost-free approach. Missouri is notable because it includes a long passage on how insurance would work under its program and what insurance would be allowed and isn't mandated to cover, et cetera, et cetera. And then lastly, Oregon has a subcommittee designated specifically for equity. And then on top of that, SB 1580, which has recently been introduced, would create the task force on psilocybin health equity if passed. Next. So Washington was notably missing from that last slide, but that's not because it is lacking in equitable approaches. It's actually one of the better states in terms of detail. So not only does this work group have one of the more extensive lists of membership composition criteria, but also SB 5660 suggested or introduced the social opportunity program, which this work group was tasked with studying. And so we will, in the 3rd meeting, we will do a far more focused and detailed look into safety. But I'm going to start off by just overviewing what the SOP does and what its goal is. And so the SOP generally, what it attempts to do is establish distressed areas based on these criteria you see here and eligible participants. And if one is in a distressed area or et cetera, has a majority ownership with individuals living in a distressed area, they can qualify for direct assistance. And that comes in a couple forms. It can come in reduced license fees. It can come in help getting the license fee. You can receive points towards a license application score. And this assistance would come from state health services or through a partnership with outside organizations. And so that's what the social opportunity program kind of writes out. And it also leaves room for people to, for some sort of group to add on to the social opportunity program if it were to be implemented. Next. So these are the bill model designations that I came up with. And what I'm attempting to do here is establish kind of broad categories that we can use to discuss what this work group sees as important for incorporating into the report to the legislature. And so I write in progress because I am looking for feedback onto if members of this work group see this as complete or not complete, et cetera. But I'm just going to walk through them real quick. So the medical model, an individual must have a diagnosis from a doctor. And so under this model, there would have to be a discussion of which diagnoses are included, et cetera. The well-being model, which is based off of Oregon, facilitators are not necessarily medical professionals. No diagnosis or doctor's recommendation is needed. The possess and share model, which was first introduced in California, is basically a more vamped up decriminalization bill. You could say what it allows for is low-level possession, is legal at a state level, and individuals are allowed to cultivate, possess, and use certain psychedelics. And so I think that's reminiscent of certain cannabis legislation, like for example in Vermont, where individuals are allowed to possess and share and use, but they are not allowed by any means to engage in any sort of commercial activity. Next. And for our last four, these are a little bit more niche, but are certainly relevant. The research model, which we see in a lot of states, calls for research institutions or government organizations to cultivate and administer psychedelics for the purposes of research, because as we know, there is a lack of research on this topic, and states would be more inclined if there's more formal research, and this facilitates the funding or at least the implementation of research. The prescription model was introduced by Rhode Island in a bill that is not very in-depth, but does suggest a model in which an individual could have a prescription for use outside a facility. The decriminalization model, as we talked about a couple slides ago, would decriminalize a certain psychedelic drug or multiple by a certain model, depending on which model the state chooses to pursue. And then lastly, we have to be determined by the advisory board, which is a common status of many of the pieces of legislation out there. And this means that the advisory board will consider various information and research documents and make a recommendation to the legislature or the governor on what model is seen to be fit. But it's worth noting that in many of these cases, the advisory board is guided by the legislation towards a certain model, most commonly a medical model. Next. So thank you for doing those slides. If you could just skip down and show the appendix real quick, just to the work group. So you'll have these slides. These are just the walkthrough of like the bill models and the date of introduction and the numbers. And then I have the links below this. And we can go back up to the questions. So thank you for your time. I'm open to all comments and questions, but these are just some guiding thoughts on what models are of interest to you, which have applicability to Washington. Are there any models that you think we need to do more research on and that the work group should study? And then also I'm open to feedback in terms of working with these definitions so that we have a shared terminology to better discuss what this work group sees as important and incorporating into the recommendation. Thank you.
Duncan, do you want to lead the discussion and respond to questions?
Yeah.
We've got a list of questions here, Duncan. This is Mike. So yeah, I think we do want to be able to hit a few questions. And Duncan, before you start, I just wanted to. This is Mike from the center. I just wanted to add a little bit more context because as Duncan went through this today, this wasn't necessarily a part of the scope, but Duncan, when he started doing this work and started compiling all this, we thought it was extremely important to get this in front of you. So that you had a better understanding of the national landscape and you start thinking about recommendations. So as Duncan kind of pulled this, we said, oh my goodness, I mean, this was just kind of a wealth of information and he educated all of us. So we thought, again, having it in front of you guys and you guys helping kind of frame up what do you like, what you don't like, and we can continue to refine this. So again, many thanks to Duncan for taking the time to do this. So we can jump into some questions.
I haven't been keeping up with the chat. Should we start with the chat or should we just start with people?
Chat's good, Duncan. That kind of started before the hands raised. So if you want to start with that, that'd be great.
Sure. Was anybody keeping track of the first question?
I I've got one question here that I saw, difference between the medical model and the prescription model.
Oh, yeah, that's worth going over. In the medical model, there is no outside use. So any use of psilocybin would take place in a facilitation center versus the prescription model suggested by Rhode Island would allow for somebody to have a prescription and take it somewhere else and take it at their leisure as directed by the state. Should we go to Emma?
Thanks, Duncan. That was really helpful. Two questions. One, are you able to share this with us? I would love to be able to look at this later. And then two, I'm wondering if there have been any kind of equity assessment associated with each of the models so that we could have some understanding of how this might play out across diverse communities dependent on health equity outcomes in each model. It'd be really helpful.
You're referring to specifically the social opportunity program or the equity models generally?
No, like the different models. So like the prescription model, recreational model, et cetera, et cetera. I mean, I'm just really aware that, the healthcare system is pretty inherently oppressive. And so it would be helpful for me to see if there is any research on equity associated with each model and how that might play out in different communities in our state. I think that research could be really helpful backing whatever recommendation that we have.
Yeah, I think that would be a great thing to look into. Certainly, because there's only one instance of actual implementation, like practical research is limited, but I bet there's more research in terms of cannabis distribution and stuff like that, even though psilocybin is certainly different due to the high cost for facilitation.
Yeah, and I can see looking at different countries too, specifically like how, also intersection with like mental health services and police services and how things have shifted in different countries who have different, drug policy.
Yeah, definitely.
Thanks.
I would definitely look into that. Jesse?
Hi, thank you. So I thought that was extremely interesting, and I'm interested in maybe following up on some of those things for maybe a second bill, like insurance coverage. But I think we need to think about the scope of what we're trying to do, and what I think the task is to take essentially the model in Oregon and their rulemaking process and try to answer some of the questions that they've been answering and apply it to Washington State. And it may be simply copying the answers that they got. So I don't want to overcomplicate this, and I don't want to make it more politically difficult, which theoretically some of this could get if we start expanding the scope. So just wanted to put that out there.
Yeah, absolutely. Sunil? Sunil might have to go to the chat.
Okay, I'm on the telephone if you can hear me. Okay, thank you. I'm in India right now, so my setup is a little different. But anyway, I just wanted to the equity thing I want to echo, and it's relevant to what I was trying to say earlier about how we really don't know. You can't really get these things if you know somebody, because there's a lot of people who don't know anybody, and there's a lot of people who can't collect wild mushrooms because they can't walk or have limited mobility or don't have a place to cultivate. You always want to think about all those different categories of people, and that's the beauty of a government supported system or backed, where everybody would be more groups of people would be theoretically accessible to. That's just one general point about equity that I think I wanted to mention earlier. But about this, your larger scope of your work, Duncan, here, I really appreciate this. And I just wanted to kind of, I wanted to point out like another angle that's happening in the country, in the United States, around this class of substances, is sort of the protections under freedom of religion and spiritual freedom developments, and a lot of those are not happening in the legislative houses as much as they're in the courts. And I think it's important to pay attention to the courts. In Washington State, I was part of a court case, the expert witness in a South Bend, Washington case a couple of years ago, where a man was, arrested for collecting psilocybin fungi in the state park down there at the Oregon border, but in Washington. Anyway, the attorney introduced a medical necessity defense, and for the first time, a religious freedom defense in Washington state for psilocybin. And I think it's just, she told me, and we looked at the Washington state constitution, it's very strong in its protections of, very broad way of defining what freedom of religion is. And I think it's also worth thinking about that just as a general concept, because we're not always, the current model has been sort of a certain type of historical dogma, like Judeo-Christian in most of the federal court rulings around religious freedom, access to entheogenic substances. But we don't necessarily have to follow that model. We can be a broader and talk about things in general that everybody has a sort of a spiritual health and center, and if these substances can help them in that. I just wanted to kind of pull out of the sort of medical recreational dichotomy a second and introduce this other sort of spiritual piece. And just to sort of take it seriously for a second, what that would look like if we actually, and given that we do have indigenous group representation here, I think it's also worth talking about that, looking at that angle as well. And that it might sort of, help us get out of some of the challenges of access. Anyway, those are my 2 cents. Thanks.
Yeah, absolutely. I think that's definitely worth keeping in mind. Tony?
Hi, thank you for the great presentation. A few points. There's been some discussion in the chat around the different models. I really like how you laid that out, especially around the medical model. I just want to highlight that the FDA is currently, taking the medical model approach with psilocybin. That's likely going to be approved in a few years. And so, that's already covered. That, is based on patents and is going to likely be very expensive, thousands of dollars per session, and will, rule out many or even most of the clients, especially low-income clients and clients from marginalized communities. Maybe someday it'll be approved by managed care or Medicaid, but that could take a long, long time. So Measure 109 in Oregon, I think, did a really good job of trying to expand, ensure access to communities that can't afford a few $1,000s in cash out of pocket. And the original bill, SB 5660, I think does that as well. Another point I want to raise is that there currently is a pretty severe workforce shortage of mental health professionals here in Washington. I'm not positive, but I imagine of medical professionals, there isn't a huge surplus. And so anything that requires diagnoses and runs through the medical system or even the mental health system is just further burdening those systems, and is going to really reduce access to people who can just fork up enough cash to pay for access. Thank you.
Duncan, I just want to add a point regarding the FDA approval and what that means. From a Medicaid's perspective, we are required through our federal contract with CMS to cover any drug that has FDA approval and qualifies for a federal rebate. And that's pretty much most every drug. States are allowed to create the criteria under which people qualify or meet medical necessity criteria for that drug. That's more correct language, but Medicaid, were it, if FDA approved and there were a federal rebate, Medicaid is required to cover those drugs. That's not necessarily true with Medicare, but Medicaid, that's how it works.
If I could just jump in for 1 second, does that include Schedule I drugs?
No, because they're not legal.
Okay, so psilocybin wouldn't be on that list.
Unless it were approved outside of research purposes, correct.
Okay, and the DEA has so far refused to reschedule Schedule I, including is currently blocking the right to try law, which was already passed specifically to allow access to psilocybin. DEA is refusing to allow that. So I don't think we should count on the DEA allowing access to Medicaid as well.
Yep. other questions for Duncan? Tony and Senator Solomon, I still see your hands up, but I'm guessing you guys have addressed your questions. Just want to confirm that. So as Duncan mentioned, these slides will be available. So all of Duncan's stuff, which again, I think is just an amazing start. So we can really start to get an apples to apples comparison, what's going on, and you guys can have a better understanding of what, you may want to kind of think about incorporating into recommendations. You'll have that. And I think, as we get kind of further refined, and as Duncan mentioned, of kind of more of an official memo will get completed in the near future, I think we'll make that available as well. All right, well, we'll keep moving. Duncan, many thanks again. And if anybody has any other questions you want to throw in the chat, we can kind of refer those to Duncan throughout the meeting and catch those by the end. I want to keep us moving. So much like we did at the last work group meeting, it was, I thought, helpful to kind of go through and make sure that we're kind of all on the same page, or at least have an understanding of where everybody is. So we had survey number 2 completed. We're going to go through those results, and much like again last time, just have a discussion around kind of those results. And we had some great feedback, and I could see the same thing after today's overview and discussion, kind of going through something similar, because I think it just kind of helps get you guys thinking about your kind of aligned recommendations. So we can go to the next slide. So for survey 2, 13 respondents. So that's kind of the end that we're looking at. And then we'll jump right in. Next slide. So everything, for the most part, if you guys remember taking this, was based on a scale of 1 to 5, 5 being strongly support. And I saw a lot of stuff in the chat already around microdosing, and Duncan, we didn't see any state activity around support of microdosing. So this is one I think you guys had even obviously talked about the last time. So the question was, how strongly would support, including a recommendation for consideration of microdosing procedures and policies. Those were some strong numbers in support, right? So 9 of you said strongly support, 1 in kind of at 4, and then you can kind of see how that corresponds. So a weighted average of 4. Right. So again, you would say that this group is leaning heavily towards, having some sort of a micro dose recommendation. So then the next question that we were trying to, kind of go about is then how do you do that? Because everything that you think about Oregon or some of these other models, whether it's the medical or even recreational under a service center, not necessarily administered at the home use, microdosing be different. So the next slide, we kind of asked this follow-up question. So again, additional feedback recommendations on how a microdosing policy framework could work. So we've captured people's comments on the following few slides. So reduce the waiting period from 5 hours or eliminate the waiting period entirely. Promote access for those end-of-life care. Look at how people in Washington are doing microdosing or even non-microdosing, and then putting some help for non-onerous health and safety policies in place. Microdoses to be attained only through qualified providers, much like cannabis stores. Next slide. Recommend following and completing further state-sponsored study on the Stamets stack for microdosing. We've got Paul here today. Additionally, recommend allowance for businesses to create microdosing level products to deliver medicine, whether in pill form or liquid form. And then we've got somebody saying, I think we lack any good evidence that microdosing has any clinical effects at this point. So I wanted to stop there and kind of open this up for some discussion like we did last time. So you saw the overall scoring. I think overall there was some strong support to move forward with microdosing. But as you guys think more about this around how, you would even think about a recommendation to the legislature around what would be the kind of the right policy framework, would love some thoughts on this. Cody.
Yeah, so once again, there's that last point that we lack any good clinical evidence for microdosing, and I do agree that there does need to be more research coming out on microdosing to really fully understand it. However, seeing that these are these are subthreshold doses that do not result in any psychoactive impairment, and considering once again the the safety of using psilocybin and the ridiculously, the LD50 is, makes it very safe. I see no reason why, we shouldn't emphatically support, making a recommendation for microdosing. And in terms of what that looks like, I 100% agree with reducing the waiting period. That it seems a little silly for someone to take a sub-psychoactive threshold dose of psilocybin and sit there for 4, 5, 6 hours. That seems a little goofy to me. So yeah, in terms of making it accessible, in cannabis stores, I feel like that might might open up a whole different can of regulatory worms that might exist outside the psilocybin services model, which I'm interested in, but I don't know exactly how that would look.
But Cody, if I could stop you for a second. So how would people access that then? If you didn't have that, how would the people access even the microdose itself?
Right. So I think it would be through the same psilocybin service centers. Through these same people who go through this process. These, I don't want to call them therapists, but these psilocybin service center providers who would be providing this normally, that you'd normally be sitting there with for 4, 5, 6 hours, and I would imagine they would get it from these same individuals. So,
got it. Thanks. Other thoughts, comments here, and Paul, I don't mean to pick on you, but since you were even highlighted here and have done probably the most work on this, thoughts from your end?
Thank you very much. It's a very interesting discussion. Somebody in the chat, Jen Author, said decriminalization would solve microdosing. I wholeheartedly agree with that sentiment. Let me just make sure that those of you who are not familiar with the literature understand. As Cody mentioned, a microdose by definition means you do not feel any intoxicating effect. The microdose publications that have come out view them with, including ours, with a healthy amount of skepticism. The microdosing studies that have come out saying there's no better than a placebo, et cetera, is one dose at a half a gram. A half a gram is not a microdose, it's a mini dose. And so the people in these studies could know, they could unmask or unblind the fact they didn't get a placebo, they got a mini dose. So the studies are mischaracterized as microdosing, and they only have them use it once or twice. That's totally contrary to the way that microdosing is being used, 3 to 5 times per week. The Jim Fadiman program is on 1 day, off on 2. The program that I'm suggesting, 4 days on, 3 days off. That is not 1 or 2 times in a clinical study that then says, oh, microdosing doesn't work. So FYI, note to self, these mini dose studies are totally irrelevant to the practices of microdosing. Also, those of you who may have seen we published 2 studies in Nature Scientific Reports. The second study is more of a vertical study. And in that study, we have, as one would make the argument, expectancy by people fighting depression and anxiety, by participating in microdosing. They're addressing a medical need. They're practicing something that could be a solution to their malady. But what interesting signal that we got was on the TAP test. And the TAP test, there was a correction in the p-value. If you have not seen this, then please look at it. Errata in scientific publications like Nature are few and far between. They're only after the editors have juried it to say the results have been significantly misstated. The TAP test p-value was 0.04 as published. In fact, it's 0.004. Now, what this showed is in 55-plus-year-olds, the psychomotor test went from 49 taps in 10 seconds to 68 taps in 30 days with 55-plus-year-olds. There's no placebo for that. There's no expectancy that would be specific for 55-plus-year-olds. The p-value is corrected in scientific reports from 0.04 to 0.004. That means the possibility that this is just random and is 1 in 250. So yes, we don't have the scientific studies right now that are currently designed to judiciously determine whether microdosing can be effective for anxiety and depression, but we do have signal. And we have over 20,000 people currently in our microdose.me app. Someone asked about geography. Great question. I'll ask our team this. So the fact that we have a psychomotor benefit, this speaks to neurogenesis. Now, those of you who've seen my talk, we have MAP kinases. These are proteins that code for neurogeneration. They're called TRK track A, B, and C. Some of my researchers are on this call right now. We have phenomenal evidence that these compounds synergistically code for neurogenesis, neuroplasticity, and neurogeneration, all three different things, by the way. And so we have the potential here of finding something that truly can help people in age. Moreover, most of you, I think, are familiar with the other studies. Dr. Zach Walsh have come out showing that a single use of psilocybin is associated with less partner-to-partner violence, reduction in larceny, theft, burglary, and generally violent crime. So we're looking at something that not only can reduce crime and help age-related neurodegeneration and neuropathies, but we have something that's sorely needed, not just for people who can pay thousands of dollars to go to a clinic for 4 days attended in a hospital. What about the disadvantaged people of low income? If we can reduce crime in the urban environments and low income individuals who are experiencing existential stress and racism. My grandson's half Black. I've had many conversations with him about, and he's told me, you know, the police have targeted him, et cetera. There is this subdued, or not necessarily subdued, anger of racial profiling with the underprivileged, low income individuals in the urban environment. So I see this as a huge potential issue that we can be addressed. Microdosing, I think, offers that opportunity. Yes, clinical studies should be conducted. And speaking of clinical studies, there's 100 clinical studies, 99 last time I checked, at clinicaltrials.gov. Now, for you physicians here, consider this. 11 of those clinical studies went through the IRB boards, and they approved niacin, 250 milligrams of niacin, opposite psilocybin. Now, what good is a placebo if it's decloaked? In 20 minutes, everyone getting 250 milligrams of niacin is beet red hot, itching like crazy. The clinical studies make no sense. Immediately, they know they're decloaked. Expectancy comes into play with a placebo-controlled study with niacin. And moreover, what is the ethos? What is the ethical concerns of physicians using a placebo that's uncloaked when then the patients suffering from depression and anxiety realize that they've been tricked, or so, quote unquote, I got a placebo, they know it's niacin, it's not psilocybin, so the depression and anxiety is increased, I would say, because they have been realized they didn't get the medicine they were sorely need. So there's a lot of really important questions. And I am really surprised and shocked that some of these individuals who are apparently so well schooled in this subject have not thought through these issues. So I look forward, and I think microdosing offers an enormous potential, non-intoxicating. You can drive, you can still, do your normal activities. For those who have, and I'm sure this is not going to be revealed, but in this organizing committee, if you have not taken psilocybin, do you deserve a seat at the table? I asked that rhetorically. Now, obviously, physicians can say, well, I prescribe lots of drugs that I have not taken. But in terms of having an informed group of decision makers, it seems to me, if you're going to teach a course on flying an airplane, you want to get it from an instructor who's flying airplanes, not for somebody sitting in the back seat, just, postulating about the different possibilities and implications. These are truly life-changing medicines. I think it's important that we shepherd this, but at the same time, I don't think we should restrict the research. And our experience, and many of you well know this with the Department of Health, I think we're 22 months in our application just to be able to grow on the size of your laptop, folks, 4 laptops of cubensis for Johns Hopkins clinical study. 22 months for the Department of Health, and we have not gotten approval to grow 4 laptop size worth of psilocybin mushroom for clinical study to compare pure psilocybin in a molecule form versus versus psilocybin mushrooms, because we know that psilocybin mushrooms have these other compounds, baeocystin, norbaeocystin, norpsilocin, which we know activate these neuroreceptors as well. So I think it's really important, eyes wide open here. People should be a little bit more circumspect and not make policy based on limited decisions or limited knowledge. I'll go back on mute. Thank you for your attention.
Paul, thanks so much. I know you're kind of a wealth of information on this front, so really it's a pleasure to get to hear you. I think before I transition away from microdosing, I think the one thing I just want to make sure that everybody understands is that if this is a potential recommendation from the work group, do you think it would be worthy to think about, then what would you be thinking about for the right regulatory framework? I mean, how would this, it's one thing to say, yes, we would like to move forward with microdosing. It's another to say how it's going to be regulated, how people are going to purchase it. Just having that understanding, I think, is going to be helpful.
Well, I just adding it to an adversive, which is already done with many other medicines. You could add it to Ipecac. If you take too much, you're going to throw up. You could add it to niacin. It causes an adverse reaction. Capsaicin, hot pepper, there's numerous adversives that all you could do is increase the adverse effects if they tried to macrodose for the microdose. So it's discouraging. Obviously, you're not going to get 100%, but those of you who have taken a large dose of niacin are oftentimes reluctant to take it again. And that's what I think the advantage of these adversives. The other thing is you could just simply make it by prescription. Many other over-the-counter drugs are done by prescription. The patients are trusted to take the recommended amount. So if you did by prescription, then this is the microdosing, I think, should just sail right on through without objection. Many other drugs are done in the same way. However, I think this is a freedom of consciousness issue. I think this is a civil rights issue. I think in order to get the maximum benefit, having as many people use these to reduce crime, to solve depression and anxiety, to participate in a revolutionary medical breakthrough. Sure, you may have a placebo effect, but you may have a placebo enhanced real effect. And physicians use this all the time. Many physicians are on board. You go into a physician's office, they imbue confidence, they tell you this could help you. Well, that placebo added effect makes the medicine work even better. So anyhow, anyone considering clinical studies going into the future, please don't choose niacin. I mean, it is unmasked. It's a very, very poorly conceived. And what good is a placebo-controlled study if everyone in this study understands what the placebo is and what the active ingredient is? It does not make any sense. Yale, Harvard, they've all made the same mistake. So anyhow, I'll go back on mute. Thank you so much.
All right. No, appreciate it, Paul. Thanks. I'm going to keep us moving. Do you have other thoughts on kind of microdosing framework? I'm seeing a few things in the chat. That's great. We'll try to incorporate that. If we have time, we'll circle back. So the next thing we asked, again, level scale 1 to 5, 5 being strongly support. How strongly would support recommending the clinical model? That was kind of the medical model that Duncan just went through, as well as the wellness model. And I think you see the scores there, right? So again, pretty obvious of where the work group has landed, much more support for the wellness model, that you don't necessarily need to have this, from a prescription or from a certain diagnosis, that it would be open, I think, much more aligned with what Oregon is looking at. You can see those scores, 2.6 versus the 4.2. Next. So again, similar, just here's the feedback that we received. And I think I saw this in the chat too, kind of a point saying, why not both? Wellness model for 3 grams or less, clinical model for anything over 3 grams, including option for higher dose choices. Clinical model will create equity issues. The wellness model seems concerning as it seems to follow a consumer model. Worries me as we don't have enough understanding to ensure safety at this stage. The more safe, structured access that is offered, the less people will seek illicit sources. Next slide. Clinical model would be an improvement over the status quo. Ideally, psilocybin service should be made accessible to anyone who needs it. Psilocybin is safe enough for most people to consume without complications. There can be facilitators in the wellness model who have additional credentials, so that option can be there for those who need it. There should be provisions for facilitation to happen in people's homes or retreat centers. I'm in favor of the clinical model if it's the only foreseeable way to get this bill passed. And we heard that several times even before this. Otherwise, a wellness model is more equitable, affordable, and accessible. Adopting the clinical model would substantially impair this bill by significantly raising costs and other unnecessary barriers to access by low-income and marginalized populations. Strongly recommend going with a wellness model due to the equity and access concerns. And then recommend age 21 years and older for a wellness model. I think that was, Beth, I think that was our last one.
Yeah.
Yeah.
One for the
Thank you. Okay, so again, I'd love just to have other folks weigh in. I kind of see where everybody is leaning, but if anybody want to have any other kind of clarifying comments around clinical versus wellness, love to hear that. Emma, I see your hand raised.
Thanks, Mike. My understanding of this is that the wellness model includes access to the clinical model. The opposite is not true. And so from my perspective, make the gate as big as possible. I mean, the medical model exists, it's already happening. I'm personally very involved with it, but it's not going to be equitable or accessible for people. And there's a lot of ways that people interact with these medicines that is outside of the clinical model. And I think the wellness model would make room for that. I don't think we need to be worried about if people are going to be able to access this in a specific medicalized environment. That's going to happen. But we do need to worry about, are people going to be able to access this in a more community-based model and a more spiritual model, and something that is more decentralized and decolonized than the medical model. And so making the gate as big as possible through the wellness model, I think, is the way to go.
Great, thanks, Emma. Sunil.
Yeah, thank you. Thank you. I was just going to say, if we do support an idea of a wellness model, which I think it seems like the majority of us do, you'll soon be met with the question of, well, is the wellness also consistent with just having to go to specific locations for my psilocybin-assisted journeys, and how can I augment my wellness by being in my community and my environment, and in a natural setting, or the traditional use models that wellness studies and integrative health is all about, helping to assure support from your community to be integrated culturally, socially, and sometimes that's going to be out of like a state licensed facility. And I just think that's a reality because of the safety factors of psilocybin and its history of use in human populations. So given that, it just sort of, if you do that, then it sort of naturally says, at the same time, we want to support wellness for psilocybin use in the community, but we need centers for people who don't have a place to do this, need more supervision. Here's licensed folks. And then out in the community, here's education, here's harm reduction, here's what you need to be, look out for, here's access, through microdosing or some other models. Honestly, I think that's actually a wellness model for me, is where it's sort of both in the center and in the community.
Great, thanks, Sunil. And I think those are great points. And I think the one thing that I'm just kind of going back to Senator Solomon's comments early on of trying to keep this within scope. I think those were some fair words of counsel as we think about this. And again, the kind of a key focus was looking at Oregon and making those comparisons and drawing kind of any lessons learned. And one of those was, the Oregon model obviously is focused on service centers and not for home use. And as you think about a wellness model that would be within the service center, is that something that, again, you guys would be in support of? Nathan, I saw you have your hand raised.
Yeah, I don't have a strong opinion either way, whether it's medical or recreational or whatever. But I think the thing that I'm most interested in is figuring out ways that we can capture some sort of data longer term, assuming that we're going to need some sort of infrastructure so we can actually see the effects of this in the community. And I feel like that's something that I'm most interested in, whether that's people doing it at home or in a center. Like, I don't really care, but I'd like to see its effects so we can better kind of target these treatments to the people that need them.
Nathan, it's a great point, and one that I think it's worth circling back on next meeting or the meeting after, because I just know even some of my colleagues who are working on the Oregon front, that is still an issue they're grappling with. I mean, how they're going to be able to get data, who's going to get it, how they're going to, who's going to analyze it, are there going to be mandatory requirements, or is it all going to be voluntary? But I think that's something very worthwhile to consider, is we're kind of trying to compare kind of results and outcomes.
That's also, excuse me, that's something that Colorado and one other state that I'm blanking on mentioned specifically in their bill, is like research into kind of the long-term care and the effects of that. So it's something other states are looking at the very least.
Thanks, Duncan. Any other thoughts, comments on Sunil? Another question?
Yeah, sorry. Thank you. Sorry. I just wanted to say that Oregon did look at things beyond service center models. I mean, that was where they started with service centers in the initiative, but in the legislative process that followed and the advisory committees and everything, there were various discussions around issues like community use and whether they should license, entheogenic facilities. That was one of the proposals. If you followed those discussions, I think it's not necessarily out of the political window, because Oregon did discuss this. And I think we can also look at it as well, and we don't have to come to the same conclusions that they did. They ended up saying, no, well, there's really no way we'll end up discriminating against some groups if we offer them religious protection licenses and other groups not. And I actually think that's a good point. So you want to start with the public health assumption that everybody has some kind of spiritual access, which is a WHO accepted definition of health. So if you do that, then you can actually make a better statement rather than sort of getting stuck in the box canyon of religion. Anyway, that's I just wanted to tell you that was also there, and it looks like there's a few folks who are interested in seeing this as well. And I think spiritual health is part of wellness. So it's sort of that if you look at the National Center for Complementary Integrative Health, the NIH division that looks at integrative health and wellness, this is part of how they think about this area of health.
Got it. Yeah, Sunil, thanks for that. I'm seeing some activity in chat, but I'm going to get tight on time here. So I'm going to keep us going. Had a question here on level support for tiered training structure. That came out of the last discussion around how, again, kind of the facilitator training could be structured. So the question was, how strongly would you support recommending a tiered training structure designed for different populations? So again, general wellness, spiritual experience, dual diagnoses, mental health, somebody with kind of a more medical credentials on the upper end, or not on the lower end. So this was a bit mixed, but I think still kind of leaning towards more strongly support. So you'll see that 3.61 was the overall weighted average. And then Beth, if we can go to the next, we had some comments on this. So I'd like our state to have the forethought of an apprenticeship training model with 302,000 training hours before certification. Don't reinvent the wheel. Don't make this another profitable venture, and don't rely on colleges. Conceptually support this approach, but it could be much more complicated to implement, communicate, and regulate. Next slide. We are not licensing clinicians here, so we shouldn't use this as a template. All the topics mentioned should be included in all facilitators' training. There is no research to support tiered training. Rather, there is considerable research to support an emphasis on experiential training for all facilitators, service providers working with all populations. I'm wary of too narrowly limiting this to certain medical professionals. Oregon's offering of training to anyone with a high school diploma is a positive aspect. And Beth, I think, is that our last one?
Yes, it is.
Great, thanks. So again, follow-up comments on kind of a tiered training structure. Yeah, Emma.
think I was the one who really pushing for this in our last meeting, and at least from my perspective, like this doesn't have to be about I'm getting internet connection stable. Can you hear me?
Gotcha. Yep.
Okay. This doesn't have to be about prerequisites. Like it doesn't need to be a tiered training in terms of like high school degree, master's degree, whatever. It can be the same level of educational requirement for everybody, but more about how long does somebody train? What kind of training do people get? For example, I'm a trauma therapist. Personally, I'm pretty terrified of the idea of somebody going into a service center, someone who has a significant history of complex PTSD, who maybe hasn't been in any kind of treatment before, and they get paired with a facilitator who has no clue what to do when somebody is in a regressed state or someone has a significant episode of PTSD come up, which is very likely to happen in psychedelic sessions. And so for me, I guess I would really love to ensure that some people are getting more training if they want to work with these kind of populations, and that there's some kind of system available to allow that and offer that for people. I know some of the training programs in Oregon they're increasing their number of hours, and they're also building kind of offshoots for people who want to specialize in different things. That's one way to look at it if this recommendation didn't want to go with a tiered training system. But I think it is something to consider what people are actually looking for, what the needs are of specific clients, and what the scope of practice is for whatever the facilitators are being trained on, because it is a huge range of what people are going to look for, and how you meet clients in different states depending on what they're looking for is really, really different.
Thanks. And I think that's something that we want to come back to even at the next meeting. Duncan mentioned it earlier, just kind of getting a little deeper dive on safety, and because Oregon is still kind of grappling with that a little bit in terms of kind of the protocols of an initial assessment and intake, and how are people screened, and then how are people potentially screened out if there are additional complicating factors, and is everybody kind of doing that across the board the same way? Other thoughts, comments here? Okay, we'll keep going. Next, so pretty straightforward support for insurance coverage. I think that was a kind of a bigger yes. So again, this was how strongly would you support including a recommendation for all psilocybin sessions be covered by private insurance? And then the next one was support including a recommendation that Medicaid explore legal and financial policies for covering those sessions with state funding. So again, strong 8s, and again, weighted average 4.38, 4.5. So you guys definitely leaning, saying, again, your discussions on equity and access leading towards, yes, this should be kind of a covered service. So nothing, I would say, too surprising after kind of hearing where the group has discussed the last couple. So Beth, do you mind hitting the next slide? Again, I would say fairly straightforward. Insurance coverage is critical for psilocybin to be equitable. Yep, strongly support subsidizing access to those with mental health diagnosis. Make insurance companies do what we want them to. Okay. Giving acupuncture as an example. Insurance and Medicaid coverage will be very important for ensuring access for low income and marginalized populations. This is medicine, and insurance should cover it. Next slide. I can see this from both sides. Equity concerns if the cost ends up being prohibitive, and 2, more expensive for all due to insurance, third-party payer involvement. Fair point. There should be parity between expectations of Medicaid and private insurance for equity and access reasons. You stop there. Tony, I saw you had your hand raised.
Yes, thank you. Yeah, I would just like to reiterate that, anything that requires DEA rescheduling or DEA approval should really just not be considered on the table. The whole reason all of us are sitting here today talking about this is because the DEA has dug in their heels and refuses to acknowledge any of the research or science around psychedelics that's been produced, over the decades. So, and I would be very surprised if managed care, was to offer something that, with the DEA still was, going around arresting people for. So I think we should just inform lawmakers that this really isn't a viable option until there's significant change. And neither political party in the White House has been willing, or the Senate has been willing to show any oversight of the DA on this issue.
Yep. Great point. Great highlight. Okay, we're going to keep moving. Got about 10 minutes left here. Sunil, yeah, question.
Yeah, just wanted, I just wanted to remind again about the fact that you can, if you look at the ketamine clinics around the country who do assisted sessions, drug-assisted therapy sessions, even though ketamine is not FDA approved for use outside of anesthesia, it is used, and insurance can be used for different sections of that therapeutic process. And in some places where clinics are completely out of network with payers, third-party payers, they offer super bills that can then be given for reimbursement, based on a few codes that are consistent with monitoring, therapy, support. I know this is moving far afield. We're talking about not moving away from a medical model, but if there was kind of a medical directorate, or if there was some kind of state understanding that these kinds of things like a health are like part of health savings plans, where certain qualified expenses can be written off or used in a health model. These are some of the, I just wanted to raise these examples of ways that you could still step away from the issue of FDA not recognizing that it's an approved drug and still get the benefits of insurance coverage of health services around the drug.
Got it.
And there's some states like in Colorado that have actually created a clinic has created a partnership with the Medicaid to cover ketamine services. So that's also a possibility for the state.
Okay, that's good. That's good to know. Thanks, Anil. So a few more pieces here. One, we kind of asked a series of questions on level of support for Oregon's model. So you'll see here kind of the support for a 2-year implementation period. I think people were, for the most part, inclined to say, yep, that makes sense. Support passing decriminalization policy, everything kind of that Duncan just outlined, overwhelming, I would say, support there. So 4.7, I think that's going to be my guess is a strong recommendation, as you guys have started to outline. How strongly would you support limiting psilocybin species to QBSs only? And you'll see that really dropped off to very, very low support. That was probably the lowest number we had. So 1.77. So again, that is not something that you guys are standing behind. How strongly would you support requiring only a high school diploma for facilitators? And again, I would say it's somewhat varied, but you're leaning towards yes, but you definitely had a few folks on the low end as well. Not all the way there. So this certainly was not unanimous, but I would say leaning there. Next, we had just the last series here. How strongly we support limiting consumption to on-site service centers only. Again, I'd say this fell below kind of this kind of fully support. So you said only one strongly support, and then the rest kind of medium to low. How strongly we support recommending that Washington's policy is similar, not include exemptions for personal, religious, or indigenous use. Again, really low on that. So looking from where you guys are, looking for expanding that, and that would not necessarily align with what Oregon has done. We support recommending that Washington's policy not specifically target populations with addiction, PTSD, and end of life. And again, you're probably leaning towards yes, but I think a bit more spread out on that one. So just so you kind of get a sense of where everybody is, and then we had some follow-up questions that were specific to Oregon. Beth, the next. So what, if any, feedback do you have on Oregon's model or implementation of Measure 109? Strongly support the implementation of home administration by service providers and allow ethnogenic use for religious leaders. Exemption should be granted to anyone who wants one on personal, religious, or spiritual or philosophical grounds. We got a few more here. should specifically target populations with addiction, PTSD, and end of life, and should include exemptions for personal, religious, or indigenous use. Measure 109 should have explicitly stated that training programs do not need to get approval from the Higher Education Coordinating Committee. So HEC, as you heard about last time, getting HEC approval is costing training programs many $1,000s. Yep, we've heard about that. Next. Given the early state of research, I have concerns about using these compounds for any indication. Seems there has to be some narrowing in use until we can better understand its mechanism and effectiveness. High school diploma okay with the additional training, where a college degree is not a prerequisite. 2-year implementation, Oregon said it wasn't enough. So do we need 3 years? And you'll see kind of the other aspects of those comments. And Beth, was that the last one?
Yes, to go into the additional feedback at the end next.
Cody, comment, question?
Yeah, I just have a procedural point. So are all these points that we've voted on before, are these going to be included in the preliminary report presented to the legislature in the 2023 session?
They will. The preliminary report is just going to be able to talk about really the first meeting and the second meeting. Okay. And then we'll be able to do some summaries, and then we'll get into the final report next year. And I think, Cody, I think you even talked about it at the first meeting, and, are we doing votes or anything like that? Yeah. The survey is being able to begin to quantify, right, where everybody is. And that will be included in the report for sure. Okay, excellent. Yes. That was my primary concern, is that we weren't going to be able to get around to voting on some of these points and present them in a timely fashion to the legislature. But that's good. Thank you. Got it. Can we go to the next? Oh, and then we had an open question. Any additional feedback? We should develop policy that recognizes the human geography of entheogens and psilocybin fungi, which people have been naturally forming for millennia. Please include questions focused on excluding the need. WASDAQ approval for 5660 programs, cost many $1,000s. Language for both wellness and clinical models that provides for integration assistance, and this be covered by insurance also. And Beth, I think, was that last?
That is.
Okay, can we go to the next? I think we had one maybe with next steps. And Charissa, I think she had to step away. I'm not sure if she's back.
Yeah, I'm back. Yeah.
So I think one thing we wanted to talk about was kind of next steps in terms of and Beth and Cody, correct me, our next meeting is not until October 31st.
That's correct.
So we've got this kind of window of time. And what we're going to recommend doing is that Duncan has done such amazing work on kind of this national landscape. We've asked him to kind of take the lead in doing some outreach to all of you for some kind of individual one-on-ones, for some follow-up, some additional follow-up questions. That will be then consolidated and kind of teased out into some key themes that we can bring back even for meeting number 3. So not looking at doing another survey, but you'll be kind of having some time with our team in between, so that we can start to kind of get into a little bit more detail from your perspectives that we'll be able to flesh out. Duncan, anything else you wanted to add on that?
No, I think this just gives an opportunity to express everybody's ideas, which have been so great, in like an easier format, and I'll do my best to consolidate them and put them into something that's digestible by the whole group. So I'm looking forward to talking to you all.
And as we are continuing to kind of get feedback, I think, HCA has done an amazing job of creating this space on this website. And then we do have this email address. So if there are thoughts, comments, questions, we're kind of constantly looking at those. You have an email address, psilocybinwg@hca.wa.gov. would highly recommend, certainly kind of funneling questions, comments to that email address that we're looking at. Okay, Charissa, I didn't leave you much time. I apologize. Just want to make sure we're teed up.
Yeah, no, thanks, Mike. Thank you, everybody. Really good conversation and exchange of comments and ideas. I don't really have much to add. Appreciate your participation, your active participation. That's what we need. We want to make sure we reflect the voices of the group broadly. And I'm looking forward to Duncan's work with all of you to help us flesh out more of the things that you feel might be getting missed in these larger conversations. So thank you for your participation, for your time. We're at 4 o'clock and look forward to seeing you back again in October. Have a good month off, as it were. Take care.
Hey, Charissa.
Yeah.
This is Senator Solomon. Can we chat?
Yeah,
maybe
I can stay on.
Chat to you, Mike. Okay.
Yeah, I can stay on.
I got to jump. Thanks, guys.
Bye.